Hello, my name is Fernanda. I work in the World Health Emergencies Department in World Health Organization on social science interventions, community engagement, and risk communications. Welcome to Module C, Community Engagement. By the end of this module, participants should be able to describe at least 3 reasons why responders need to engage communities during an outbreak, list challenges faced in community engagement, and describe approaches for effective community engagement in detecting, preventing, and responding to an outbreak. We know that affected communities and populations need to know how to protect themselves, and response teams, at the same time, need to know how communities understand the disease and the response. Generic public or media announcements are not sufficient, trusted, or tailored to communities at high risk. We know that engaging with communities allows their direct participation in the response to address fears, barriers, concerns, and to change transmission-enhancing practices while promoting protective behaviors and working together with the response team. Populations at risk want and must be a part of solutions to protect lives and stop an outbreak. Bidirectional communication, dialogue must be established from the onset of an outbreak between affected communities and response teams to ensure participation and mutual understanding. This is the base of trust building. When we will see opportunities to engage with communities, basically throughout the process, in anticipation and preparedness, during early detection of an outbreak, during the containment phase of an outbreak, and during the mitigation phase of an outbreak. Throughout, communities must be engaged in the process. Lack of understanding of community practices, concerns, and fear by response teams are challenges that are common in outbreaks. Other challenges also are the slow and late information release about the disease and the response. This could exacerbate community concerns and amplify the outbreak. Lack of information and awareness on protection measures can aggravate the spread of the disease. Starting implementation of measures without the agreement of communities impacts the acceptance of the response. If people don't know what is going to happen, they will not accept what is going to happen, right? Late and no action taken to stop rumors can lead to misunderstandings and impacts trust in the health authorities and promotes dangerous behaviors. Other challenges that we have during outbreaks are, for example, the problems we have with the nosocomial transmission. These can be amplifiers of the outbreak, because there's no proper information and awareness about the virus at hospital level. Healthcare workers are not well informed, are taken by surprise, and they fail to apply appropriate infection prevention and control measures. And this is a real challenge. Another challenge are, I would say, challenge because certain cultural practices related to caregiving and healthcare seeking behavior may make it difficult to control the outbreak. For example, some cultures might demand relatives to accompany and visit sick family members when in hospital. Some people may go to many different hospitals or many different caretakers while sick before they decide where to seek care in the proper place, like say the professional care system. This is called sometimes doctor or hospital shopping. As you can see, this may enhance transmission as people are moving around if they are sick, transmitting the virus, in different places. There is a way to strategize, a way to tackle this community engagement during an outbreak. So we can strategize. We have to define the engagement during an outbreak. So first, what we need to do is to assess the contextual qualitative information. We have to understand what is going on at community level in the context before we decide how we're going to intervene. After we get this information, we have to define an engagement and communication strategy with the key people identified in the assessment. Once we define this strategy, and we of course identify what resources we will need to implement this strategy, we will go and implement the activities defined in the strategy. Then we need to monitor this strategy. This is very important to understand if what we decided to do has a positive impact in relation to outbreak control. And if it doesn't, during the monitoring process, we will be able to modify and adjust according to needs. One of the first and most important things we need to do is to identify these key people we mentioned before. The key stakeholders can be, for example, government, official and spokespersons, healthcare practitioners, media and social media influencers, women as main caregivers at home, business and employers, general public from where patients are being reported, workers in healthcare settings, travel and trade sectors workers, and people using the travel sector, of course. Local government and civil society, women and youth associations, and religious and community influencers. All these groups are very important to be identified because we will need to define a strategy for each group to make sure all key groups are being addressed and we can outreach to them and listen to what their concerns are. How can we assess the context? For example, we can consult local colleagues and stakeholders, wherever we are, local people from the place where we are working, people that know and understand the needs, the concerns, the fears, as well as the strengths and capacities at community level. Always, we need to look at both sides of the coin. We look at the problems and concerns, but we also look at the potential and the capacities, positives and negatives, we can put it like that. We need to review existing literature, CAP surveys, that is knowledge, attitude and practices surveys that already exist, ethnographies, political science analysis to understand power dynamics in the region and in the area where you're going to be working. We can apply social science methodologies, very quick and very simplified, community walkthroughs, just to observe by participant observation what is going on in the place we're going to be working, focus group discussions, and interviews with key people. We also need to explore what are the preferred communication means of different communities and different groups. Literacy levels, for example, is very important to be taken into account because when you have a low literacy level, you will move into more media and audio production of materials to be able to reach these audiences. So, to continue the assessment of the context, we need to identify the health-seeking behavior pathway for the disease. This health-seeking behavior pathway means what will people do once they get sick, what kind of help they will seek and how they will do it. We need to understand what factors condition this health-seeking behavior locally. We identify sociocultural factors that define this or affect this health-seeking behavior pathway, and these include explanatory models, which means how people understand the disease, how people understand the origin or etiology of the disease, the localized gender vision, and the power dynamics. We also identify economic factors that condition the pathway. For example, if people need to pay for the services, would they have the money available or not to be able to access these services? Practical factors, for example, if we are in a rainy season and then the access is difficult to the hospital or clinic, this will condition the health-seeking behavior, of course. Also, if there's a conflict and it's not safe to go walking around, then people will think twice before going to seek for care in a hospital. We also have what we call empirical factors that can condition this health-seeking behavior. Empirical, we mean the experience that people had previously in this particular hospital or clinic where they seek care when they were not treated in a way that they consider correct. So this will condition them to go back to seek for help in the same place, right? In this clinic. We also need to identify the people who are already linked in this health-seeking behavior pathway. from home level to community level to the health provider level. We can identify certain, say, groups of people who act as gatekeepers, decision makers, influencers, and caretakers and health practitioners. To give you an example, at home level, who takes care of sick people at home level? Let's say in most cultures is the mother. The mother is the one who will be the primary caregiver at home level. So she's identified as a caretaker. Then who might be a gatekeeper or decision maker in health decisions at home level? Maybe the father. The father has power over this. Even though the mother is taking care of the sick person, then the father will decide who can go out to seek for help. Then who can be an influencer for this decision maker or gatekeeper? Mother-in-law, maybe, the mother of the father. So we identify these people, and it's a very important identification because then we will know with whom we need to engage to achieve the objectives that we will define for the strategy. Same thing we need to do at community level with the identification of these people and at the healthcare provider level. Once we identify the people, we are defining the audience for the engagement and communication strategy. We define these key actors and the target population. We will design the communication plan and choose the communication channels and methods at 3 levels. Mass media, that includes social media, leaders and key people, and interpersonal communication. We're going to develop engagement narratives. What are the engagement narratives? Engagement narratives are composed of, on one side, what is the biomedical message, meaning what are the key information or the advice that is being provided from the professional sector to the communities. But we will combine that with the information that we assess at community level, understanding how people perceive the disease, how people name the disease, what are the worries that people have. So by combining these 2 sets of knowledge, we will prepare these narratives to give responses with biomedical information to the questions that arise at community level. After that, we will develop IEC materials and tools together with the end user groups. We will test the materials before using to make sure that this is meaningful to them and that also transmits the information that we, in the biomedical sense, want them to receive. It is very important to, throughout the response, and as we spoke before, at all stages we will have engagement, right? So we need to build this dialogue and to build a feedback system that will stay throughout the response. It has to be systematic and it has to be dynamic. We need to collect this information, to analyze it quickly and integrate the feedback, the rumors and misinformation at the 3 levels. Same levels as we discussed the strategy. The mass media, with the leaders and the key people, you can get feedback directly from them by doing interviews with them. You get the leaders' feedback, how they perceive the situation, how they feel the communities are accepting or not accepting the response, how they are acting, how they are behaving. In the interpersonal communication level, we can create and develop community dialogues, and we can get community workers' feedback that people who are in direct contact with the communities can send back the information and the questions that communities are asking on a daily basis. Once we ensure that we collect this feedback from the communities, what do we do with it? It is very important to share this information with the other technical areas of the intervention. In this way, we will have to negotiate change and improvement in the implementation of the response according to the feedback that is provided by the communities. We have to ensure this daily collection of information. We have to analyze this data and we have to negotiate the feedback with the response and always get back to the communities with answers to their questions. This is vital. And this is the reason why a feedback system needs to be set up. We will be negotiating and bridging 2 realities, the reality of the community and the reality of the response. And this is a very important work because that facilitates the dialogue and the trust building within the community and within the response, and across both knowledge systems. So let's summarize the key points, some of the key points that are essential for this unit. Communication and information dissemination is not community engagement. Community engagement is more effective when relationships and mechanisms exist before an emergency. Engage community engagement partners routinely and build trust. Be honest and transparent. Connect and bridge the reality of the community and the reality of the response. Communication can be defined as the action of exchanging, sending and receiving information. What are the common barriers to communication? Could be language and education, cultural and ethnic differences, irrelevant messages, too much information, time constraints, noise and distractions. What are communication enablers? Reach the intended audience, attract audience attention, engagement narrative is understandable, culturally adapted, credible and relevant, and delivered in time. So thank you very much. This concludes this module in community engagement. If you require further information, you will find details of a contact person to address your questions and concerns. Thank you very much for your attention.